Can I have the slides, please? Yeah. Very good afternoon. So I'm going to be talking about the long-term outcomes of external DCR in revision surgery in a previously failed SAC surgery. So this is a retrospective, non-comparative interventional study conducted at a tertiary eye hospital in South India with a study period of 2014 to 2022. All the case records of external DCR done during the study period were reviewed, and patients who had undergone revision surgery were included in the study with a minimum follow-up of 3 months, and patients without required follow-up were excluded from the study. The surgical technique basically includes a tear trough incision or a previous incision in case of revision surgery, and MPL was disinserted, adequate sized osteotomy was performed, anterior flaps were sutured and anchored to the muscle, followed by skin closure. And in this study, I've used bicanalicular stent. No MMC was used. In case of acute dacryocystitis, patient was treated with antibiotics for about a week, and surgery was done after the complete resolution of symptoms, usually after 2 weeks. So during the study period, we had about 900 cases of external DCR, and 45 patients had revision surgery, which accounts to 5%. So after excluding the patients without proper follow-up, we had 36 patients in this study. The mean age group is about 55.6 years, and there was female preponderance, and 4 patients had bilateral CDC, but however one eye of the patient was included. Presentation from the previous surgery was from 3 months to 40 years. The type of surgery, when we analyzed, it was most commonly, it was a previously failed external DCR, which included 5 of my own patients. So that was found in 19 patients, and we had laser DCR and DCT in 7 patients, and there was failed probing in 2 patients, and there was a failed endoscopic DCR as well. So the reason for presentation was, the commonest reason was a persistent rhoplas, which happened to be in 17 patients, and some patients presented prior to the cataract surgery. So local anesthesia, which was supplemented with IV paracetamol or sometimes conscious sedation, was used. Standard DCR, as I already described, and intubation was used in about 31 cases. The tube was removed by 3 months. So the success criteria here is both anatomical and functional success rate, a complete patency, and absence of epiphora at the end of 3 months. So we had the results where 35 patients had both anatomical and functional success rate, which accounts to 97%, with a mean follow-up of about 27.74 months. So the commonest reasons for failure included inadequate or absent osteotomy, and soft tissue obstruction due to scarring in post-external DCR failure. So when we compared our study with the previous studies that happened, most studies were retrospective in nature. Almost all studies utilized an intubation tube, and the reported success rate ranges from 74 to 91%. And the mean follow-up sometimes was not mentioned some of the studies. But as you can see in the previous studies, like analyzing outcomes in DCR is very difficult task, because we have different success criteria, as in anatomic patency in some, improvement in tearing, and sometimes the full resolution of symptoms were taken as success criteria, which was not uniform. And the follow-up period was also widely varied. So if you go only with the anatomical patency, that can sometimes overestimate the success rate, and more than one surgeon was involved. So when you compare this, the strength of the study would be a single surgeon, uniform surgical technique, and well-defined success criteria in a technically challenging group. And the problems were, this is a retrospective study, so we do not know the number of exact causes of failure, which was not evident from medical records in some cases. And the intraoperative and preoperative factors like pre-op anesthesia and surgical plan and things for bleeding could have added more value, and I have not evaluated the use of MMC in this. So to conclude, DCR is a technically challenging surgery in revision cases, but if you use good anatomical steps and a meticulous surgical steps with adjuvants, usually the success rate is good. Thank you so much.
I did you prefer to use nitromycin or generally prefer individual surgeries?
Yes, ma'am. In this group of study, I have not used, madam. And my practice, I don't use MMC as frequently as you. I use in post-traumatic cases more frequently, and pediatric cases also I use, but not routinely in my practice.
Why specifically post-traumatic?
Because the scarring could be more difficult there to deal with. So I prefer to use MMC in those cases.
Any case there was
Just
nasal
advance, ma'am.
pathology?
Sir, no, none of these cases had nasal
Because
pathology.
you require a nasal evaluation also.
Endoscopic examination was
Endoscoping.
done in all these cases, sir, but however there were no endoscopic.
So retrospectively, I think you can also use intubation tubes in the primary stage also, if you feel that it's a complicated surgery.
Yes, sir. I do use in primary setting also if the flaps are not good, if there is an increased surgical time, or sometimes if I feel it might fail, so I use definitely intubation.
Yeah,
tube.
that will
But
help
this was
in.
a subset of patients where it was previously failed cases.
Okay.
So I prefer to use intubation in many of these cases.
Thank you.
Thank you so much.